So have you ever thought about getting a coronary calcium scan or getting a calcium score? One and the same thing. Well, here's why I believe that you should. A coronary calcium scan is a low radiation CAT scan that is designed to look at the arteries of your heart. This scan looks at the arteries in a relatively qualitative manner. In other words, it doesn't look at the arteries and tell you whether or not you have a 5%, a 20%, a 30% blockage or a degree of plaque buildup. Rather, it gives you a sense that you have some degree of plaque buildup and it's early, or that you have a moderate amount and it's kind of intermediate risk, or you have a lot and you may be at high risk for future coronary events. And when we say coronary events, we're talking about heart attack, the need for, intervention where we'd have to go in and do a heart catheterization, maybe put in a stent. So this will give you a lot of insight with regards to that whole process. So what it is, it's a CAT scan. It's not a blood test, it's a CAT scan. And the CAT scan is really a very simplistic one. You basically put into this donut, not a tube, and it's not like an MRI where you're claustrophobic and you're all kind of caught up and there's stuff around you. Frankly, there's nothing above your head in this CAT scan. And because you're under the scanner for such a short period of time, most people really have no trouble with it. There's no preparation. You don't have to fast for it. You don't have to have an IV placed. Really, it's as simple as they come. And it provides a tremendous amount of information. So who should get it? Well, if your age is between approximately 40 and 70, that's probably about the sweet spot in terms of those who get it. We do it for people who are younger or older. For instance, if you had a family history of heart disease that started in someone's 30s, let's say your father or uncle or brother, someone had a heart attack in their mid or late 30s, well, you would probably want to get something like this before that. So I usually tell people to start screening themselves for cardiovascular disease as far as family histories of heart disease, 5 to 10 years younger than your earliest relative who was afflicted with heart disease. So that would be a reason to get such a scan younger than the age of 40. If you're older than the age of 70, there are some reasons as to why we might get a scan as well. And the reason could be to adjust medications or to frankly give us a sense if you're otherwise healthy and have no risk factors and other than age, maybe you have lurking heart disease and you don't know it. But it can also be something that reassures as well. Additionally, if you have more risk factors, let's say you're diabetic, let's say you're overweight, let's say you're sedentary, if you've got high blood pressure, if you already have high cholesterol, one of the best tools that we can utilize to objectively determine whether or not you really need a statin or a cholesterol lowering medication approach is to do a calcium score to determine whether your arteries have started to plug up. In other words, is there the presence of atherosclerotic plaque in your arteries yet or not? And this is an objective way of finding it, because if you have, let's say you're 45 and you really shouldn't have heart disease or you shouldn't have any atherosclerotic plaque burden within your arteries, no cholesterol deposition, and your cholesterol numbers are decent, let's say they're even normal. But if we found evidence of atherosclerosis, even at a minute level in someone who's 45, I'd probably put them on a cholesterol-lowering medication, because now we're talking about prevention. This is all about prevention, frankly. So this calcium score study is not designed to tell you whether or not you're having a heart attack. It's not designed to tell you, if you have chest pain, is it possible that it's coming from my heart or not from my heart? Because unfortunately, this only looks at calcium. So back in the day, they used to call this process hardening of the arteries that we now call atherosclerosis. Calcium basically gets deposited in your arteries where there is cholesterol plaque. So where cholesterol plaque starts to accumulate, your body kind of tries to protect itself. And by putting calcium on, it actually makes that area less likely to rupture. So having some calcium in your arteries isn't exactly bad, but it's bad if you shouldn't have calcium at all. In other words, if you're 45 and you shouldn't have any calcium at all because you shouldn't have any atherosclerosis, well, that's not as good as if you had no calcium or no atherosclerosis. But my point is what you can't see with this is you can't see the non-calcified plaque. And that's an important distinction. Non-calcified plaque, or basically soft plaque, when cholesterol starts to deposit into the arteries and you have just a little bit of plaque that's building up, it takes time for it to become calcified. So you could have a calcium score of 0 where there's no detectable calcium, but you could still have non-calcified plaque. And if that non-calcified plaque ruptured, you wouldn't be able to see it on a calcium score. So you could be having a heart attack and still have a calcium score of 0. So I know that sounds funny, but that's the reality of how our bodies work. So calcium scores are best utilized to try and predict your future risk of having a cardiac event. And it's probably best at predicting it between the 3 to 5 year mark. So the more calcium you have, the higher that risk is. And then we basically use that as a tool to adjust, the degree to which we want to throw either medicines or interventions at you. I'll yell louder at my patients if they have a high calcium score when they should have no calcium. Meaning that I'll tell them to exercise more. I'll tell them to, tune their diets a little bit more towards a plant-based. But we'll have these conversations about how aggressive that we need to be depending upon what the framework of our bodies are doing. And when I say that, I'm referring specifically now to the calcium score. So who else shouldn't get a calcium score? Well, you shouldn't get a calcium score if you're pregnant because it's radiation. So just a simple maneuver. No radiation should be given to a pregnant female unless it's super, super critical for the health of both the female as well as the fetus. But those people who have also already had established heart disease, let's say you've had a bypass operation before, let's say you've had a coronary stent, if you've had even documented atherosclerosis previously, well, getting a calcium score really isn't going to help you now because the process of calcified plaque has already been established. If you've had a bypass operation, which is, I'll talk about in another video, it's where you basically have arteries that are implanted inside or veins that are implanted inside that bypass or circumvent areas of blockage. Which means that you've got a blockage, which means that you don't need a calcium score to tell you that. Likewise, if you've had a coronary stent, you've already been established with coronary heart disease or atherosclerosis, and a calcium score isn't going to help you. So if a physician tells you that you need a calcium score and you've already had one of those two things, tell them, I don't think so. All right, because unfortunately in this day and age, sometimes doctors will recommend things simply because of the fact that it makes them money. And that's wrong. So it's coming out of your pocket because oftentimes insurance doesn't cover these things. This is a screening test. It's a screening tool. So if you're going to cover it, if you're going to pay for it, you want a return on your investment. And you're not going to get one if you've already had a bypass or a coronary stent. So calcium scores are not for that population of patients. So the calcium score comes as a score, like a numerical score. So 0 is best. But as I said, you can have soft plaque that's not calcified and still have a 0 score. So that's where it's not a perfect test. But the lower the number, the better. If you have a score of less than 100, you're generally considered to be in the low risk population. But unfortunately, that depends on your age. If you have a calcium score of 50 and you're 30 years old, guess what? That's not low risk. That's a high-risk scan because of the fact that you're only 30 years old and you shouldn't have any for a decade. So it has to be taken with context. If your score is between 100 and 400, at that point you're considered to be an intermediate risk for having a future cardiac event. And then if your score is greater than 400, you're considered at high risk. Now, the absolute magnitude of the score, in other words, the higher that number, 400, 500, 800, does not directly correlate with having a blockage. So imagine if you have an artery that has calcium that is basically all throughout the vessel. It's lining the arterial wall. You can also have calcium not only inside the vessel wall, but you can have calcium outside the vessel wall. And that calcium score that might be high, let's say it's 800 or even 1,000, does not tell you where the calcium is located. So you could have a calcium score that's very high, 800, 900, 1,000, even 5,000, and not necessarily have a major blockage. You might very well have a lot of calcium throughout your heart, and that does put you at high risk for having a future coronary event and absolutely has a response in terms of the level of aggressiveness that we treat you for. But it's not something that necessarily correlates to a blockage of 80, 90, or 100%. Sometimes it can, but it's not a predictable measure. So that's why we do, when we have someone who's got a high calcium score, and we want to know, is there a blockage? Is there something that's preventing blood flow getting to the heart's muscle? Then we do a stress test. And the best kind of stress test to do is something that images the heart muscle as you're being stressed. You want to basically do something called a stress test with an echocardiogram or a stress test with a nuclear agent. Most commonly is used as what's called technetium. So nuclear stress test or a stress echo will tell us a lot more about the blood flow to the heart, because we want to see that during stress, the heart muscle functioning properly, like all territories, all parts of the heart squeezing normally. And we also want to see whether or not the blood flow is adequate. Now, when I say blood flow is adequate, we look at the heart muscle, like on a nuclear stress test, and we see whether or not all of the muscle takes up the nuclear agent that we injected. It's a pretty easy study. Both these things we do very routinely in our offices typically, so it's not like a hospitalized study, and it'll provide you with a ton of information. So if you have a high calcium score, don't panic. It's something that we see a lot of, and it is something that we can manage. So it's not a death sentence. It's not something that you have to go and really start to worry about, but it is something that requires action. So I would highly suggest that if you're between the ages of 40 and 70, or have a family history of heart disease that even starts younger, the additional risk factors that we talked about, I really think that getting a calcium score is a super effective way and a highly profitable way of investing in your health. It's something that provides you with information that no other test can really provide. A stress test won't tell you this, an EKG won't tell you this, an echocardiogram won't tell you this, nothing will. Not even a blood test that shows your cholesterol is normal will tell you this. I have patients whose cholesterols are normal, yet they're at high risk of cardiac events because their arteries attract plaque, attract cholesterol in a more aggressive fashion. And that could be based on their genetic biology in terms of how their arteries actually behave, not about cholesterol. You know that there's a significant minority of patients who come into the emergency room having had their first heart attack with no prior history of high cholesterol. It exists. So our bodies are complex and don't always make a lot of sense in terms of how we tend to think about things. But you have to realize that you can have heart disease without risk factors, including heart disease with a normal cholesterol. I've even had marathon runners who've had heart attacks, and despite being super diligent about taking care of themselves. So there's a lot that goes into the whole diagnostic process of, do you have heart disease, or are you at risk for heart disease? And I do think that the calcium score is one of the most effective ways of us digging into that further. Thanks for tuning in. Hope you learned something. See you next video.